Okay, so hi, welcome to Nipped and Toxxed. With me is Dr. Killeen. Hey, Kelly.
Hi.
So today we're going to be talking about gynecomastia. So for those that aren't aware, gynecomastia, gyno means female, woman, mastia is breast. So it's basically a man that has female-looking breasts. Most men aren't into that, but there's a subpopulation that would like that. But for the most part, we're going to be talking about that diagnosis. What are some of the causes? What are some of the treatments? So gynecomastia, there are three spikes in the aging process of men. So first one is in that neonatal period, and that has to do with just being exposed to the circulating estrogens in utero from your mother. And so I'm trying to think of if my son, maybe I shouldn't like call him out. I can't remember, if he did have it, it wasn't like memorable, so I don't know. But like having that is like very typical. Then there's another spike around puberty where, obviously girls get breast buds, but a lot of boys do too. And I think it was somewhere around, oh gosh, I can't remember the statistic. It was something where like almost 2/3. Yeah,
Yeah,
somewhere it
it's a
says
lot.
60 to
It's very
80% of
common.
boys. So that's a lot. So not that I think a lot of teenage boys are listening to this podcast, but I think going through puberty is a time in your life when you're really unsure and you feel uncomfortable in your body. And so I can't imagine for a boy like having little breast buds. They're not going to like that, or they're going to feel a little bit uncomfortable. But it's very, very common. In fact, more common than not. You're more likely to have something there than not. But then that usually goes away. And that has to do probably to some extent. It's like, okay, you have this spike in testosterone because your body's undergoing puberty. But if you have a little too much, that excess testosterone will aromatize into estrogens, and then you get that extra chest breast tissue. That's what happens with men that take exogenous testosterone too, is that they're getting, in many cases, too much testosterone, more than what their body wants. And so the body just shunts it over, and that steroid pathway that, either you do or don't remember from medical school that you had to at one point know it. It's just like a chemical reaction. If you've got too much of one, it's going to go into the estrogen or the aromatization pathway. So that happens a lot with men that are getting supplemental testosterone. And certainly I see that in my practice as well. And the third peak is around the older population. So in your 70s, you just get some of that extra breast tissue as well.
A lot of men don't recognize that they have breast tissue in there. So men and women both have ductal tissue, and they don't
Yes.
have globular tissue that women have. That's what makes the milk and allows us to breastfeed. So of course men can't breastfeed, but they do have some breast tissue in there. And so just like you'll see in women, there are some asymmetries and differences in how your body has tissue on your chest, just like women do with breasts. Like all women have a little bit of asymmetry, men do too. And so sometimes we'll see men that, they have a little bit of tissue on one side that doesn't bother them, but the other side has more. And so one side is really what brings them in to see us. And so, yes, men, you do have some breast tissue.
When I first got out and practice, I feel like maybe I didn't spend enough time educating my patients. And I would have men coming in saying like, I got to get rid of all this breast tissue. And I'm like, well, I'm going to remove most of it, but I don't think I really focus on the fact that, hey, like it's not possible. I mean, it probably is, but at the consequence that you'd have this huge divot, right? Like you're going to have some residual glandular tissue under the nipple and areola. And if your primary goal was eradication of all glandular tissue, it would be an aesthetic downgrade for sure. The goal for gynecomastia is contour, right? You just don't want to have that increased fullness. So yeah, for the most part, you're leaving a little bit of gland no matter what technique you're utilizing.
Yeah, some of the worst revisions I've done in the recent years have actually not been female breast revisions. They've been gynecomastia has gone wrong, where
Really?
too much was taken in the central chest by a well-meaning general surgeon, and they had a giant dent with the nipple adherent to the pec muscle, and it's a really
Oh
difficult
man.
problem to solve. Yeah, so it's definitely a surgery that I think doesn't always get all of the respect it should. And it's definitely a surgery that you want to see someone who's well qualified to do it, because it is something that the aesthetic outcome really matters, because men go shirtless and you
I think
want
that's a huge thing. That's
yeah, it's
huge.
a thing. And so I'm a general surgeon too, so I can feel qualified saying this. We just aren't properly taught the aesthetics of the male chest and how to preserve them in general surgery. And I really think this should be a surgery that's primarily done by plastic surgeons.
Oh, yeah, I agree. The other thing with regards to gynecomastia is that it kind of falls into two categories, and that true gynecomastia is an increase in the glandular component of the breast. And then there's the pseudo gynecomastia. The truth is, I think a lot of people have a little bit of both,
Yeah.
but pseudo gynecomastia means that there's more fatty tissue there. Now, that kind of diagnosis will improve with weight loss. So if, the thing is, like, usually if you have pseudogynecomastia as a man, there's excess fat in multiple locations. And so with weight loss, you can assess and see, hey, as I get closer to my ideal weight, is this problem resolving on its own? In some cases, it will, but for people that have a true gynecomastia component, interestingly, what I find is that as they get more lean, the residual gland just becomes so much more apparent. They don't have
Yeah.
the adipose tissue there for camouflaging purposes to kind of hide it in like a billowy dough look. They're just seeing, okay, here's a lean pec muscle, and then wow, there's this glandular component sticking out beneath the
Yeah.
areola. Now, that being said, they're often treated in very similar ways, whether it's just all gland or gland and fat. And we can get into that in further detail, with the exception that glandular tissue doesn't suck out via a cannula quite as well. It's just dense. And so that obviously creates a little bit of a challenge.
It's a challenge. And, there are some newer minimally invasive options where we can remove
Yeah.
glandular tissue. And yeah, the goal is, of course, whenever we're dealing with the male chest, is to have scars that are hidden and minimal, because again, they are going topless.
Mhm.
And so having a mastopexy type scar like you would do on a female patient
Mhm.
is usually not something that our patients want. It's always important to talk with your patient and find out what they're willing to tolerate, what their aesthetic goals are, and figure out how to get them the chest of their dreams with scars that are as hidden as possible.
Yeah, that always depresses me when I see the traditional kind of anchor pattern, Weiss pattern, lollipop pattern, whatever you want to call it, reduction on a man. Because
It's
first of
feminine.
all,
Yeah.
you're adding all those scars, but also just to move the nipple and areola, you're maintaining this chain of tissue that still has a bulk to it.
Right.
And it's more than what would be ideal from like an even subcutaneous fat layer. So yeah, I've seen a handful of those over the years that they're just not good. I mean, I just don't like much about them.
They don't look good, and they're not something that most of our male presenting patients want. The other problem that we're having now is that, a more ideal, especially for people that have a lot of skin ptosis, is like a 2 incision, where there's an incision around the nipple, or the nipple's on as a skin graft. And then there's a kind of a horizontal incision that just goes along the border of the pectoralis major muscle. But now that has the stigma of being top surgery. And
Yeah.
so we're having patients that are not excited about having that because they don't want to be seen as someone who had top surgery, because, there's stigma for everything, unfortunately, right now in the trans community. So
Okay.
it's a complicated thing. You really have to have these in-depth conversations with patients and make sure they understand where the incisions are. Luckily, there's a lot of patients that don't need those big incisions at
Yeah,
all.
for sure.
You probably remember our attending Dr. Mueller. He was a big advocate of doing as little as possible with the gynecomastia patients because the skin shrinks really well. And he's
Mhm.
absolutely right. It does in a pretty significant majority of people, even when they have skin laxity.
If you think that there's a reasonable chance that the skin will shrink back to the extent that you're satisfied, I feel like it makes sense to try that first. Like, you can always come back and add some excisional type procedure to your chest wall. You can't undo it. Like, once you add those scars, yeah,
There.
maybe you can make them better, but they're there. And like you said, you're walking around a beach with your top off as a man and you have those scars. They're just hard to hide.
They're hard to
So
hide.
yeah.
Yeah, I agree. I guess what we should probably go into diagnosis. So like what do you do when a gynecomastia patient comes in the door? Do you make them do any kind of diagnostic testing, or is it just off to the OR we go?
Well, I mean, just like every patient, having a really thorough history and physical exam is important. Figuring out what are some of the predisposing things that could lead to this diagnosis for you. So, like age of onset, duration, those are important. Did this just happen overnight? Was it related to a new medication that you started? Have you had it since puberty? I mean, that's the most common story I hear, is that,
Yeah.
okay, well, I noted it at puberty and then it hasn't really gotten better. Oftentimes they'll give you like a family history of that same kind of issue in their family, but not always. Then like getting a medication history, like the list of medications that can cause gynecomastia is actually pretty extensive.
Yeah,
I'll
it's
just kind
huge.
of rattle off a few because I think some people would be surprised at some of them, some that are pretty routine medications. So estrogens, obviously, gonadotropins, the androgens that we were talking about earlier. If you're a man and you're taking exogenous testosterone, some of that can aromatize into estrogens and give you increased chest wall fullness. Anti-androgens, chemotherapy drugs, the calcium channel blockers, so medications that people will take for hypertension, for example, that can cause that. ACE inhibitors. So ACE inhibitors and ARBs are actually some of the most popular hypertensive, antihypertensive drugs that is. So ACE inhibitors can cause gynecomastia. Anti-tuberculosis drugs, that's probably not as common. Heroin, obviously if you're on heroin, that, I would guess your gynecomastia issue is secondary to other health issues, but still a history of heroin use could be at play. Methamphetamines, marijuana is a big one. The popularity of marijuana use throughout the country has really been increasing. People seem to be not only using it more, but also more forthcoming with their physicians about marijuana use. So that's definitely a known risk factor. Some of the H2 blockers like cimetidine, spironolactone, ketoconazole, which is the antifungal, omeprazole. So GERD is a really common problem that people have. So reflux disease. Some of those medications have been associated with increased gynecomastia risk. Other things that I think make us worried, like could this be some kind of testicular or adrenal neoplasm, right? We don't want to miss a cancer. And so certainly from a plastic surgeons or anyone providing care for the kind of patient, you don't want it to be just totally overlooked at as a theoretical possibility. Is there something neoplastic that's either creating a situation where there's extra androgens or estrogens in the system? So that has to be ruled out. Weird things like Klinefelter syndrome, where you've got you're an XXY, you've got an extra X chromosome, thyroid problems, liver problems, adrenal hyperplasia, malnutrition, and you already talked about aging. Those are some of the things that you're looking to parse out in a patient's history. And I'm not like, do you have congenital adrenal hyperplasia? Like, I'm not asking people that question every time. Because the truth is that most of the histories are like what I said, like they've had it for 15 plus years. They see their regular doctor. They don't have testicular masses. They don't have some sudden onset change. And so in that regard, yeah, I'm not doing like lots of lab workups because most people fall into that typical history. But if it is atypical, then yeah, you have to, as a physician, adjust things based on the evidence that's presented. You have to order tests as appropriate. I don't like, oh, well, here's 500 tests. Let's just order them to see, because the utility of that is probably pretty low. How about your approach?
Yeah, the utility of ordering all these tests are very low. The most common thing we're going to see is just, aging, weight loss, and weight gain. Those are the things we typically see. But because there are some rare things that can be serious, it's really important that, if you're a patient with gynecomastia, this is definitely a problem you want managed by a real plastic surgeon. You don't go to a liposuction shop to have someone manage this. You want to make sure that everything is done safely and properly. I would say that a pretty significant amount of my patients actually come already having a workup done, because a lot of patients are not happy with how things look, and they read online. People are very educated, have access to information, and they want to make sure that there's not something that they could fix to make it go away. So I often have patients come in already with a note from their doctor. We've done X, Y, and Z and everything looks good, but it's very important to really make sure that the patient is healthy. And it's also important to recognize too, if you are on any of these medicines that may have caused it, sometimes you cannot come off of these medicines. It's the best option for you for whatever reason. So it's fine to treat a patient with a medication-induced gynecomastia, and they can continue on those medicines, and they rarely have trouble after surgery.
True. Yeah, I get asked that a lot. Like, will this come back? I mean, the likelihood is extremely low, but we can't foresee the future or whatever future
Never can
changes.
promise in medicine.
Yeah,
Never can promise.
right.
It is unlikely though.
So that gets into the management issues that we were talking about a little bit before. So yeah, I would say with the exception, okay, of true pseudo gynecomastia, where you could do a weight loss program and make improvements. The truth is that like most people, if that was easy to do, they would just do it, right? They're not going to come see you 50 pounds overweight thinking, hey, if I lose weight, will I be smaller? Like they already know that. And that doesn't mean that they're not a candidate if they just have extra fatty tissue. But from a aesthetic perspective, the closer you are to your ideal body weight when you're thinking about contouring procedures, the better off. That means there's just less variables that are at play long term. In other words, let's say you're 50 pounds overweight and then you have your pseudo gynecomastia treated with liposuction. Yeah, it's going to look good. Then what if you decide you wanted to lose that 50 pounds? Is that area going to be maybe a little bit too thin? I mean, just, we don't know. I mean, probably not, but maybe.
Just never know. And I've done a bunch of social media content about this. You know, liposuction doesn't age well. That's just the reality of liposuction. Whether you gain weight or lose weight, the skin laxity, the scar tissue internally, it can be problematic as you age, and you throw big shifts in weight like that in, and it could look strange, and you could end up with an odd appearing chest. So anytime you do a surgery, your goal is to be at a stable body weight. And it doesn't mean that you have to be a BMI of 18. It just means you have to be a BMI that is achievable and sustainable and healthy for you. And so you're more likely to have a nice long-term result with minimal problems if you do that.
And I think it actually comes into play even more in the chest for men because of the glandular and the fatty component. Like I was saying earlier,
Right.
the goal is to just create this nice uniform layer where it looks like, okay, it's just sub-Q fat over your nice bulging pec muscle and it looks great. But you know, we're just seeing it at one point in time. So we're going to leave that normal layer of glandular tissue under the nipple and areola, and we're going to remove the excess part, and we're going to leave a normal layer of sub-Q fat more laterally. But any kind of fluctuation, the challenge is that the glandular part doesn't fluctuate with weight changes. So you're just introducing these additional variables that make ultimate ideal contouring more difficult to achieve. So
Right.
yeah, I mean, what you're saying, the closer you can get, and that's not, like you said, that's not me saying, yes, you have to get to a BMI of 23 or whatever the great number is. Usually 18 to 25 is considered ideal. But the closer you are to whatever you like to be or whatever you consider ideal to yourself, that's going to get you the best result. So assuming the weight loss isn't going to be the method that a plastic surgeon is going to offer you, although I'm sure it should be discussed, then we start talking about what are some minimally invasive treatments. Or there's also the excisional approach around the bottom of the areola. What do you like to do?
So I live in the land of sunshine and nice weather year round with people wanting to be shirtless. And so the scars are really important. So my preference in most patients is ultrasound assisted liposuction, which is also known as Vaser. And then if there's glandular tissue that I can't bust up or remove with that, then I like something called a Miller procedure. It's a minimally invasive lesion or lump removal. And it is a minimally invasive probe that has like a little rotating chomper on the end of it. And under ultrasound guidance, you can actually remove the glandular tissue with this minimally invasive probe. And that all can be done through one couple millimeter scar on each side. For someone that doesn't need any skin tightening and everything you think is going to shrink back where it should be, that's really ideal in my opinion, because then you just have a little scar that we hide it right along the edge of the pec, and you already kind of have a crease there anyway, and it's difficult to see. I often don't need to even do the Miller procedure. We can just do liposuction if you don't have a lot of glandular tissue. And the nice thing about that is just you avoid the scar on the underside of the areola. The problem with that scar is just that everyone knows why you have that scar. That's a pretty pathognomonic scar in male presenting patients. And it's basically, you know, look what I had done, and it's nice to avoid that if possible. The Miller procedure is not available everywhere though. I personally don't do it. My breast surgeons that I work with will do it with me. And I probably could do it, honestly. I just, you know, I don't do it.
Easy. Yeah.
Yeah.
So it's just it's the same tool for like,
Yeah,
it's a microdebrider blade, right?
right. It just
It's like you
rotates like
said,
this and
yeah, it's like
pulls
local.
it out.
And essentially the difference is between a cannula and the microdebrider is that there's a cutting component. So that really
Yeah.
dense glandular tissue that just won't suck into a cannula. It gets into the little opening and then it's chopped off and sucked up. And
Right.
so I do that. I don't use ultrasound guidance because I don't really feel like I need it. Like I can feel where just like I can feel where the cannula is for
Yeah.
liposuction. I can
And the
feel where the
right
cannula
you
is.
can feel. It's just ultrasound's nice just because you can really see the difference between the fat and the glandular tissue, especially if you've already liposuction. So it's just you can really see that you got what you think you're getting. Downside though, it bleeds like stink, tons of bruising and hematomas. So that's the only downside to that
It does.
procedure.
That definitely bruises more, like you said, higher risk of seroma for sure.
Sure.
Um,
Absolutely.
So yeah, I still don't put in drains for it. What I try to do is I try to get it as close as I can with the liposuction, and so that I'm just using the microderbeater for the part that needs it, and I'm not relying for the majority of the contouring. And that way I
Right.
can minimize how much is being essentially cut and oozing and seeping and bleeding.
We're using Tumescent too because it's
Oh,
liposuction.
yeah, yeah. Yeah,
And
for sure.
EXA is
That's
helpful. There's things we can do.
that
It's just
does help.
bruisier than a typical liposuction patient.
Yeah, and then some people are bruisier than other people, as you well
Right.
know. When it comes to making those kinds of decisions, a minimally invasive versus a true excisional approach, I mean, like you said, with regards to that infraareolar, I'm just gonna debulk some of this subglandular tissue without a lot of excess skin. That's not my favorite either, for the reasons that you already said. It's that telltale obvious sign that you had as a man, extra fullness there. I think the kind of the lateral access points along your lateral chest wall, along the pec, hide pretty well. You really can see both of them at the same time, which is a helpful facet with regards to hiding scars. From a skin excision perspective, it has to do with whether or not the patient has a lot of laxity, like how low is the nipple and areola relative to its ideal location. And for us, we call that ptosis, like how much droop is there, how much extra skin is there. I agree with the prevailing thoughts that when possible, minimally invasive should be your first approach. But for some men, there's just so much tissue. And that's usually like the patients that have lost a lot of weight. You've got like so much droop and you've got breast tissue folding over itself and just so much skin. The nipple and areola is well below that IMF or the inferior border of that pectoralis major muscle. Then those are the patients that you really have to talk about. Would you benefit more from an excisional approach?
Yeah. Yeah, I mean, it's all, some patients, it just depends on what their ultimate goal is. But if you got a lot of skin, you got a lot of skin, and there's just no way
Yeah.
to tighten things up without removing skin. And then the question is, what is your incision pattern? You and I trained with someone. Most of the ones I saw as a fellow was with Dr. Mueller, and he loved the bat wing, which I hate. I hate the
Oh, I
bat
don't
wing.
use that at all. Never.
I never use it. He loved
Sorry,
the
Mueller. No, thanks. It's just like,
it should be
what's
illegal. It's
good?
like a felony to do a bat wing, but he loved the bat wing. My preference is the 2 incision, where you have just an incision along not the IMF, but the pec border.
Yeah.
And depending on, there's a lot of people, the nipple sensation, I think is an important consideration. So especially if you're excising stuff under the areola, you're almost certainly going to have loss of nipple sensation. Believe it or not, with the minimally invasive removal, you tend to keep it, which doesn't make sense to me because it seems like it should go, but it's typically patients keep their sensation. A lot of patients are very squirrely about a skin graft because, of course, for obvious reasons, they don't want to lose sensation. But the reality is that trying to preserve a pedicle that your nipple is living on it's going to be so thin you won't have sensation anyway, and then it'll just leave strange bulk in
Oh,
weird places.
mhm. Yeah,
So
I don't do that either.
it's a difficult thing to talk with patients about, of course, because nobody wants to hear I'm taking your nipple off and putting it back on as a skin graft, but it's often going to lead to the best result in patients that have a lot of skin excess.
It's funny because, well, so like you were saying earlier, the vast majority of men that I see are candidates for the minimally invasive. But I will have to say that for my excisional patients, that I don't know, maybe it's an Indiana thing or a Midwest thing, but when I tell them like, yeah, I have to cut off your nipple and areola and stick it back on, they're like, whatever. They don't even care.
I wish my patients
So
were that easy, but no,
they're
I mean,
not concerned about the erogenous benefits of their nipple and areola for sure. They're like, whatever, you just got to do what you got to do. So
yeah, there's more concern about that in my rightfully so. People deserve to be concerned about those things. It's hard to balance the aesthetics and the performance of whatever procedure we do. We want people to look good, but we also want them to feel good in their bodies. And so again, that's why you always talk about everything with your patients, so they understand
Oh,
why you're.
absolutely.
And then sometimes if it's not wrong, but it's not what I would do, that's the best choice because it's what makes sense for the patient, not necessarily me.
True. But so, okay, say someone says to you, like, I really want to maintain the best sensation possible. It's a trade-off, right? You're going to accept increased fullness and bulk in order for maybe slightly improved sensation. I don't know. If I have patients that say like they want all glandular tissue removed, even after I feel like I've explained to them why that wouldn't really be likely, then, then it's okay. Like they can see another surgeon. I'm okay with that.
Yeah.
I'm not going to win every patient over. And the truth is that they'll find someone to do exactly what they want, probably. And I've seen this before, not just for gynecomastia, but then they'll come back several years later saying, oh, I should have done what you said. Can you fix this?
People have to make decisions in a path that makes sense for them sometimes, and it's not always the path we would choose for them.
Yeah, and that's their prerogative, and that's fine. One thing that I think is that obvious, and this blows my mind, that I'll see other surgeons that create a round nipple and areola, and that drives me
I'm glad you mentioned
crazy.
it drives me crazy too. And so there's weirdos that study this for people listening, which is always what makes me crack up in plastic surgery. The ideal male areola is going to be actually an oval and not round.
Yeah.
And usually about 2.5 centimeters by 1.5 centimeters, a pretty classic definition. And it's going to be placed right where the pec muscle starts to curve up. So it kind of goes straight across your chest and then curves up towards your armpit, just slightly up from that edge of your pec muscle. And there are far too many round areolas being made. And part of the problem is, especially if you are doing like a circumareolar incision and you're not doing a skin graft, is that just a circular incision is going to stretch with time and look round. I don't want to give out too many details, but we'll just say that there is a place in town that does a lot of this on very fit young men where they do areola reductions on them and they don't need it. Like they're just completely within normal. And then now you've given this fit young man a round areola that will certainly spread with time with an obvious scar.
Oh, that's awful.
It breaks my heart. Everyone I see, I just want to block the person on social media.
Like we were talking about before, that scar is even the best version of that scar is still a tough scar.
Tough scar.
So I feel like you'd have to have a areola the size of I don't know, like bologna's, not
it would have to be pretty big. I mean, and there's honestly minimally invasive things you can do to try to shrink the size. I would do that before I would do anything.
I would too. Yeah. And I do that. So one thing I'll do for patients that have a little bit of skin laxity, and obviously we're trying to avoid any kind of excisional part, is I'll bring in Body Tight, that radiofrequency soft tissue treatment. I'll also do Body Morpheus, which is like the microneedling for those patients. And certainly if you're still in that normal range for a male-sized areola, like I would explore all of those minimally invasive tightening options before you accept a circumareolar scar, because that scar, it's even tough on women that are classically wearing bras and bikini tops all the time. It's tough to pull it off and have it look really good on them. And for a topless man at the beach or the pool or whatever, it's going to be
the edge of the areola is not a sharp, crisp edge, right? Like the pigment kind of melts into the surrounding pigment. And whenever we do it surgically, we create a harsh end to the areola pigment. And so it just looks unnatural at baseline. Even if the scar heals perfectly, it gives you a bit of an unnatural look to the area. And that, of course, if you're a man and you are not wearing a shirt in public and out at the beach, it's going to be very obvious. And there's no other surgery that does that. It's that pathognomonic scar. Everyone knows what you did. And I just don't think it's worth the trade in most people.
I can't say I've ever done just an areola reduction for the sake of an enlarged areola on a man. That's the only issue he has, just as areola. This hasn't been someone I've seen, but it doesn't sound like something that would be worth it.
Nope. Agreed.
The other thing that I'll see, not real commonly, but men don't like overly projecting nipples. And so if we're talking about a feminized chest wall, gynecomastia, I think having too prominent of nipples would fall into that category. Men's nipples are obviously from a diameter perspective, quite a bit smaller, but also they project less. And so doing a nipple reduction, and more of like a deep projection is really what it should be called, is not that uncommon with some of these patients as well. I think the most unforgiving is like the dry fit shirts, right? Like those athletic shirts that men wear, whether it's a dry fit or the rash guard shirts where it's super thin, super clingy, you can definitely see very projecting nipples. And I don't have, I guess I've never done it because I haven't had the demand for it, but I supposedly Botox will help for that too.
Yeah, that's the word on the street. I mean, Botox to me never makes sense because you have to repeat it so frequently. I mean, who wants to do that? It's such an easy surgical
And now you're
correction.
doing it on your forehead. I mean, just be like, okay, we'll save a couple for here. I don't know.
I can barely remember to do it on my forehead, to be honest with you. I'm so terrible about remembering the maintenance of
Your
life.
forehead looks good now.
I think I need some, but
Okay, maybe. Okay, maybe you're just like really good at holding it. So maybe you need a little.
I know that's my practice for all these years. But yeah, I mean, it's such a simple surgical correction, and there's ways to do it that just are literally scarless. There's no scar left, especially if you just remove the distal nipple tip and then contour with an iris scissor. It heals and repigments and looks like nothing happened. I don't know. I can't imagine not doing that.
Yeah, what I'll do a lot is like if you think about the nipple like a cylinder, you can just also de-epithelialize the length of the cylinder, and then you're just kind of telescoping it in on itself. And I feel like that works pretty well.
It works well. I would do it more in men than women because it kinks the ducts, and so it can cause breastfeeding trouble, but it does leave a scar. Whereas, you have a scar around the base of the nipple. So I'm a fan of just amputation. I think it looks better. I didn't believe it until my partner does a lot of them when I moved out here, and you can't even tell. I would look at op notes and I'd be like, no way did she have that done. And it just heals perfectly. It looks kind of pink at first, and then it repigments and it's like nothing happened.
Have you done it for like African Americans?
Yeah. Dark skin. It's amazing. It's just like burn patients where everything's kind of pink right after it heals over. And then you'll see the little stem cells come out of the hair follicles, and then the pigment will move across. It's the same idea. You'll see little dots of pigment appear, and then it will completely cover, and it looks like nothing happened. It's really one of the true scarless things that I do.
Yeah, for some of the skin grafts on my patients with more melanin for the nipple and areola, the pigment obviously does improve, but I feel like it's never, in some cases, it's never like 100%. Like when you're doing a whole areolar skin graft, like you can have little pale spots.
Yeah, but this is
For
just
those,
thing though. Just, you know what I mean? It's like not a big area. It works really nicely. Even if it
yeah,
never came from the middle and it just came from the edges, it would be rare that you wouldn't get at least a centimeter in.
if you do have just only a pigment option, is that you can always have tattooing, right? So there's so many tattoo artists there that can fill in little pale spots. And that can be a nice option, not only for the nipple, like you're talking about, but for some of those areolar pigment changes. And so I'll have some patients that do that, although most men don't seem to care about the slight color irregularities.
No, it's better than where they started, so it's usually good.
What other major problems have you seen with regards to bad outcomes?
I mean, I would just say in general, poorly placed scars, doing weird things to the areola, and taking too much out. I think liposuction is one of these things where people have this idea that the more you remove, the better. And it's really not the case at all. It's how much you remove and where you remove it. You don't want to be too close to the skin. You want to leave a natural subcutaneous fat layer so that things match the rest of your body. And like you said earlier, if you lose weight, you're more likely to have it lose weight in a way that matches you and doesn't look weird. So
Sure.
that's really what you want. I had a patient the other day in the office tell me they wanted me to take it down to skin on muscle. And I'm like, no, you don't.
Really?
I know it sounds,
Sounds
like
good.
sounds good. Get rid of everything, but that's not good. That's not how a natural body looks. And it looks weird, and you look surgical in a bad way.
Mm-hmm. I think it would be hard, for example, a patient that is a bodybuilder in those phases when they're very lean, but they take exogenous testosterone. So they're super lean, but they just have some of that subareolar fullness. Like that can be a little more complicated because along where in that whole path where you're trying to hide, you have that laterally placed incision, and really you only have a tiny bit of bulk under the areola. The good news is that most of those patients that get that lean, like they're just that way for like a little bit.
I had an MMA fighter once that was like that, and he got
Yeah,
down to 3% body weight.
right.
And you could see it when he was very thin, but not when he was larger. And so we just waited till he wasn't actively
Yeah.
competing. That's what needed to be done.
Right.
So
That's the approach that I've used, is that trying to work on someone in their most extreme lean physique would be more challenging. But yeah, most men or women for that matter that cut down don't maintain that weight long term. They have some pretty notable fluctuations. And so you're better off trying to tackle it not at the
yeah.
nadir of their body weight, like when they're a little bit higher.
You know, one thing you didn't mention, which people always ask me, is insurance coverage. So this is a
Oh.
procedure that can sometimes be covered by insurance. I wish it was more consistent, but it certainly doesn't seem to be. So the way that it works with insurance is that you have to have a diagnosis code that matches a CPT or procedure code. And so depending on the insurance, your insurance may cover nothing with gynecomastia. It may be a code that is not covered in any circumstance. They may cover excision only, or they may cover excision and liposuction. So it just depends. I think any patient with gynecomastia, it's always worth checking with your insurance and seeing. Depending on your insurance plans, sometimes you can even go to whoever the heck you want. And even if they don't work with insurance at all, you could try to get reimbursement yourself, or you can work with a surgeon that will help you through the process. I always do recommend, like I said before, is that you see someone who's very skilled with chest aesthetics if you're going to have this done, because it is an aesthetic procedure ultimately, and you want it to look.
In other words, don't select your surgeon because they take insurance and they're not good at it, but you can have it covered, because some of these techniques that are utilized that we had already alluded to, once the damage is done, it can be really hard to correct, like especially external scarring. And some of those patients are too much volumes removed, and then you're not going to get that covered. You're not going to get your liposuction fat transfer to fill in divots covered. You're not going to have the scar revision covered.
That's important too, is that revisions are often not covered. So you got to make good decisions. And so going to the general surgeon that's in network who does only lap choles, appies, and colon resections is probably not the best choice for a good chest aesthetic outcome.
Oh, I'm sure no.
But, you know, I mean, there are some general surgeons that are skilled at it, especially ones that do a lot of breast in general and they live in the chest. I still think plastic surgery is the way to go, though.
There are exceptions to every rule, right? There's going to be people that don't have the traditional or ideal background or training that could still be good at something, but it's certainly, I think, more of a gamble. So when you're thinking about who's going to be the most reliable person to give me the best outcome possible, I don't know. Like, I don't think I would just want to go for the gamble. You want to just pick based on someone who has the training and expertise. So you can certainly, just like every other surgery, look for that person's before and afters. I feel like that's always a good recommendation. It's nice if if you have word of mouth. Unfortunately, I feel like for me, like a lot of the women I see in my practice are direct referrals. I don't really feel like that's the case for men as much. Like, I just don't think that they want to talk about their gynecomastia reduction with their buddies. And
Right.
so
I agree. I'm not sure I've ever had a gynecomastia patient come referred from another one. Whereas most of I'd say a very large percentage of my female population that I take care of is referred from a friend that had surgery with me, or, follows me on social media or something. So yeah, I agree.
the only ones I've had have been like family members, right?
Right.
Like I've
Yeah,
had
something like
a
that.
couple, like they'll share it with their brother or whomever, and that makes sense, but they're not telling their work buddy or their friend. And I
Absolutely.
get it. But
Yeah, I mean, men aren't as communicative as women. We know this. This is a well-studied thing. So, and there's stigma to it. So I understand as well. It's just kind of, I was talking about it with a friend the other day. It's kind of like labiaplasty. Labiaplasty patients are not talking to each other either. That's not a
not
patient.
as much.
I don't get them referred from another labiaplasty patient. That's a very private surgery. And gynecomastia surgery seems to feel the same way.
I see a lot of men at the pool and at the beach that I would think, hey, they would just be such a great candidate for this surgery. And it's minimally invasive, and you're in and out, and maybe you're wearing. That goes to recovery. From a surgical perspective, if we're talking the minimally invasive approach, it is outpatient surgery, as is the excisional approach. For me, it's a couple little handful of millimeter incisions laterally placed on the chest wall, sutures that are under the skin. They're absorbable, usually a layer of skin glue. And then I put my patients in a compression vest.
I do.
Um, and they're wearing it for a couple of weeks, some more than others. And it really just depends on how much swelling they have. But from a restriction perspective, I don't really want people like aggressively working out right after surgery. So I like them to take it easy for a little bit. But beyond those first couple of weeks, they don't have any restrictions. They can shower right away. I want those incisions to be healed before they stress them out with lake water, ocean water, pool water. But recovery wise, like it's not very painful.
Yeah, most patients say subcutaneous surgery is typically one of the easier tolerated surgeries we do. Most of my patients don't even take any of their prescription medicines we give them. They just take over the counter things. It's typically for the average patient easy. Liposuction, though, is one of those things that once in a blue moon, you have a patient that has nerve pain and then they can have more tenderness than expected. But for the average patient, no, it's pretty easy.
Fair. And I use a lot of Exparel, which is that long-acting local
Yeah,
anesthetic.
love it.
And yeah, and for my patients, they barely even really need Tylenol. Their requirements for pain medications are so low. I feel like that makes recovery and your ability to return to normal activities pretty smooth. I don't think people take off a lot of time following the surgery, like pretty minimal. When you start talking about excisional approaches where maybe you're doing a nipple and a reeler graft, skin graft, that obviously adds a little layer to the postoperative care because there's usually a dressing over the nipple and areola so that you're making sure that that skin is sticking down to the underlying bed of tissue so that it gets a blood supply and survives, et cetera. So usually a dressing that is taken down at around a week out from surgery. I don't put drains in those patients. Do you put drains in your excisional? Yeah, me either. So there's not that part, but yeah, the little bolster dressing, it's just there for a week. And they also have compression vests as well.
Yep. Yeah, it's a pretty easy recovery. Most patients are back working within a handful of days. You're usually released to literally anything you want to do by 4 or 5 weeks after surgery. Like I said, one of the easier recoveries of the things we do to people.
Depending on what they have had done, like the minimally invasive, I see them at 2 weeks out and they already look pretty good. They're still a little bit swollen, a tiny bit bruised, but they're doing all the things they want to do. They already look pretty good. They're already seeing some of the obvious contour improvements. And so I think like I said, from a post-operative course, it's fairly easy.
Right. And male patients are always so funny. I rarely will see them after 1 month. They never come back. They just, men are kind of like, "Well, I only come if I think I need you," and they never think they need me after a month. So they'll not show up to their follow-up appointments, and we'll call them like, "I'm great." I'm like, "Okay, great. I'd still like
Yeah,
to
I
see you."
get it. I mean, like I kind of, like I get it, especially when you have patients that live some distance away, for them to like take time off work and drive however long for your 15-minute appointment for you to be like, looks good,
Right.
right?
Yeah.
Um,
It's always I can't get too annoyed at it because I totally get it, but they
yeah.
never feel like they need me. So I think that first month is pretty easy healing, and after that, it's like pretty much nothing.
So yeah, you got to get your post-op photos on at the 2 week because the attrition
Oh,
rate for
yeah, for
follow-up
sure.
is pretty high. They're like
Yeah,
they never
that's
come
one of
back.
those surgeries where I will accept a 1 month follow-up photo because I never see them again after that.
And the truth is that most of the time, like further out, they just look better because there's a little less bruising, a little bit less swelling. You've seen the skin, especially for the skin contraction. When I do the body tight, like it takes a lot longer. But yeah, if they're not going to come, you only have the photos you have. So that's a reality for plastic surgeons, right? Things that are procedures that are really easy and that people do super well with, like maybe they're not coming to follow up, or also, so you may not have photos. And also, I feel like that's a little bit true for the face as well. They don't want to share photos that reveal who they are to the world. And I understand that too. So that can be, sometimes I can get it to like, okay, well, what do you think about this? Right. Like,
Right.
photos that are cropped down to, let's say the nose, or you'll see a lot of photos are just like the eyes, and it's something, right? But
Yeah, that's hard.
yeah, it is hard. Some people don't care, but a lot of people do. So it just makes having photos to share a little more challenging.
Yep, absolutely. But like I said, we understand. We're not the center of our patient's universe, and we would love to see them, but we understand that if they don't have a need for us anymore, they don't have a need.
So that's pretty much all I have for gynecomastia. From a procedural perspective, a surgical perspective, it's a pretty sweet, straightforward surgery, outpatient, fairly quick recovery. And the satisfaction rate is really high. So as far as surgeries for men go, I feel like it's a good one.
Yeah, absolutely. I say most men have a 10 out of 10 experience. It's a huge, like huge change to their physique. They can go shirtless in the summer and feel comfortable. The scars are easily hidden usually. It's just, like I said, 10 out of 10.
Yeah, I agree. Well, cool. Thanks for talking to me about gynecomastia.
Absolutely. Anytime.
All right.